respiratory effort during NIV, and can NIV worsen self-inflicted lung injury? So these are my disclosures. I don't think it's anything related to the current presentation. So what I would like to discuss in the next 15 minutes. So what is the concept of self-inflicted lung injury? What do we know about effort during non-invasive ventilation? And does NIV indeed worsen lung injury? So first, very favorite topic of mine. Let's start with respiratory drive. The respiratory drive originates from the brainstem. There are respiratory centers in the brainstem that generate respiratory drive. And these centers obtain feedback from the body. And there are three main pathways. First, chemoreception. The strongest contributor to drive is probably pH, CO2. A little bit decrease in pH has a very strong effort on respiratory drive. PO2 has less of an effect on respiratory drive. Secondly, cortical, the cortex, higher centers have a very important effect on drive. You all recognize as clinicians, patients agitated, anxious, delirious, have a higher respiratory drive. Patients with neurotrauma often have a very high respiratory drive. And third pathway, and very important for the current presentation, there are irritant receptors, mechanoreceptors in the lung, chest wall, diaphragm. And upon activation, by consolidations, atelectasis, inflammation, increase respiratory drive. So the pathways of respiratory drive, activation of the respiratory centers in the brainstem, chemical feedback, CO2 pH, cortical feedback, and reflex feedback. So again, what's the concept of self-inflicted lung injury? I guess you have seen this slide many times, but just to review, there is lung injury, a consolidation. This results in capillary leak, lung edema. Again, remember, activation of these irritant receptors, impaired gas exchange, perhaps lowering PO2, increased CO2, and this increases respiratory drive. And the increase in respiratory drive increases respiratory effort and may result in lung injury. So what are the mechanisms exactly? How high respiratory drive, or I should say effort, results in lung injury? First, let's focus on the transpulmonary pressure, the pressure that distends the lung and is actually the damaging pressure to the lung. Take this example. This is a healthy subject under controlled mechanical ventilation. At the end of inspiration, alveolar pressure is 9 centimeters of water. Pleural pressure, 1 centimeter of water. So the lung distending pressure, in this case, 9 minus 1 is 8 centimeters of water. This is a patient under non-invasive ventilation. Again, at end of inspiration, alveolar pressure is more or less the same, 10. But now, because of the action of the inspiratory muscles, the strong effort, pleural pressure is negative, in this case, minus 15 centimeters of water. So transpulmonary pressure, the lung distending pressure, is 25 centimeters of water. So that's how a high respiratory effort may result in lung injury. Other mechanisms include, and I don't have time to go into detail, but include generation of Pendeluft, high transvascular pressure, the pressure within the lung becomes negative, pulmonary edema may develop, and poor patient-ventilator interaction. So the first conclusion is that a high respiratory drive, especially during non-invasive ventilation, may enhance lung injury through several mechanisms, and this is the concept of patient self-inflicted lung injury. So what do we know about effort in patients under non-invasive ventilation? Well, there's actually not a lot of studies, but I would like to pick one. So this is a nice study by Domenico Grigo and Massimo Antonelli and colleagues, published in the Blue Journal 2 years ago. Patients with acute hypoxemic failure. It's a crossover study, randomized order, 6 minutes of each intervention, high flow, and after that or before that, non-invasive ventilation with the helmet interface, pressure support of 12, and PEEP around 10 of 12 centimeters of water. As you can see right here, under high flow, swings in esophageal pressure as an estimate of the pressure generated by the respiratory muscles was around 15 centimeters of water, quite high. As you're sitting in this room, this pressure would be 3, 4, 5 centimeters of water. And with the initiation of helmet non-invasive ventilation, there was a significant decrease in respiratory effort. Looking at transpulmonary pressure, the lung distending pressure, there was no significant difference between high flow and helmet NIV. Okay, so now the most important question for this talk. Does NIV worsen lung injury or the effort by the patient? Let's go back to this important study. So, published in the New England Journal of Medicine, 2015. So these were patients with acute hypoxemic failure, mainly due to pneumonia, randomized between non-rebreather mask, non-invasive ventilation, and high flow. The primary outcome was the proportion of patients requiring endotracheal intubation within the first 28 days. Now I'm going to do a little bit of cherry picking, because I'm only going to show the data of patients with PF ratio below 200. So this is not their primary endpoint. This is a selection of patients. But for the topic we're discussing, I think this is quite interesting. It shows the cumulative incidence of endotracheal intubation, which was higher, significantly higher, in non-invasive ventilation as compared to high flow or conventional oxygen therapy. To me, this was quite surprising at that time, actually. What could be a possible explanation? Well, it's nice to go back to this physiological study again. Carton and colleagues looked at patients on non-invasive ventilation for hypoxemic failure and looked at the role of tidal volume. Is there a relationship between tidal volume generated under non-invasive ventilation and NIV failure? 62 patients, mainly patients with pneumonia, 52% failed NIV. And patients successfully treated with NIV, mean tidal volume was around 8.5 ml per kilogram. While patients failing non-invasive ventilation, tidal volume was 11 ml per kilogram. I know this is not causation, but it's an important observation. And in additional analysis, they showed that the high tidal volume was an independent risk factor for NIV failure. It makes us think, at least, right? Okay, I think this is a very interesting study for this topic. Published by Antonelli and colleagues in the Blue Journal 2 years ago. Patients with acute hypoxemic failure, mostly, again, pneumonia, ARDS. And patients were assessed at different time points, just before and at the institution of non-invasive ventilation with a face mask. So this is not a helmet study. And their hypothesis was that excessive respiratory effort is the determinant for NIV failure within the first 24 hours. Right here. So at T0, before NIV, T1 is after 2 hours of NIV. And the first thing, at least it's remarkable to me, that these patients had a very high respiratory effort. Remember, your swings in esophageal pressure are around 4 or 5 centimeters of water. In these patients, it was 30, 35 centimeters of water on a non-rebreather. In general, institution of mechanical ventilation decreased respiratory effort. It's a good thing, right? But if we look at a little bit more detail, in patients failing non-invasive ventilation in the first 24 hours, respiratory effort did not decrease. While in patients successfully treated with non-invasive ventilation, respiratory effort significantly decreased. So it looks like here that respiratory effort is an important predictor for the success of non-invasive ventilation. Looking at the lung distending pressure, the transpulmonary pressure, as you can see in the failure group, it significantly increased during the first 2 hours, while there was no significant difference in the group successfully treated with non-IV, but we have to admit that the response was quite heterogeneous. Very important observations, I guess. And this is a quite complicated picture, but interesting as well. So On the x-axis, you see changes in chest X-ray before the start of NIV and after 24 hours. On the left side, in red, these are the patients where chest X-ray deteriorated, and these are the patients where chest X-ray improved versus the changes in esophageal pressure by non-invasive ventilation. The bottom line is, if non-invasive ventilation decreased effort, you were more likely to improve your chest X-ray. And the authors took this as a suggestion that self-inflicted lung injury plays an important role. I think it's a fantastic study, to be honest. So the higher effort, does it result in lung injury? Do we have additional evidence? This is also a very interesting study published in the Blue Journal, also 2 years ago. Admittedly, this is an invasive ventilation, but I think there's a lot to be learned from this study. The retrospective analysis in COVID patients, all endotracheal intubated, and P.1 and occlusion pressure, as non-invasive estimates of respiratory effort, were measured on the first day that these patients were on an assisted mode. And the primary outcome was the relapse of respiratory failure within the first 24 hours after occlusion pressure were measured. And their definition of respiratory failure, relapse of respiratory failure, was a little bit complicated, but basically it was a decrease in PF ratio or increase in CO2. So what about P.1? So in patients that did not deteriorate, P.1 was relatively low, 3 centimeters of water. While patients that deteriorated while being on an assisted mode, P.1 was significantly higher, almost 7 centimeters of water. And more or less the same was found for the other occlusion pressure. So this study also suggests that a higher effort is associated with deterioration of lung injury. So in the last few minutes, I would like to discuss, well, some ways how we can modulate this drive in patients with high effort. I started this talk by telling you that the respiratory drive is determined by cortical stimuli, chemoreceptive stimuli, and mechanical stimuli that provide input to the respiratory centers. So we can modulate this by sedation, extracorporeal CO2 removal, setting inspiratory assist, but I would like to go to setting expiratory pressure, setting the PEEP. How does setting PEEP affect respiratory drive? Admittedly, this is again invasively ventilated patients, but I want to make a point right here. Invasively ventilated patients with ARDS. 5 of PEEP, you'll see here the changes in esophageal pressure, around 10 centimeters of water. The only thing that was done in this study is increasing the level of PEEP by 10 centimeters of water. And as you can see, there's a significant decrease in esophageal pressure swings, in respiratory effort in these patients, and a decrease in transpulmonary pressures. So in these patients, higher PEEP results in lower effort. We can discuss later on how that exactly works, but I think it's an important observation. And then in the end, I would like to go to this study. Perhaps thinking about PEEP helps us to interpret this study. So this is the very famous NIV trial, also from Domenico Crigo, Massimo Antonelli and colleagues, published in JAMA, where patients with acute hypoxemic failure, were randomized between helmet and high flow. So high flow, 60 liters per minute, and helmet, 12 of PEEP, so relatively high PEEP. And the primary outcome was the median number of days free of respiratory support in the first 28 days. I guess you all know there was no significant difference in the primary endpoint between the helmet and high flow. And again, I'm going to do a little bit of cherry picking. I just take one of their secondary endpoints, so we have to be careful with the interpretation, but again, I think we can learn from this. They actually demonstrate that the relative risk of intubation is lower with the helmet as compared to high flow. So what I would like to show to you, what I've shown to you today, is that physiological and pilot clinical data at least support this important concept of patient self-inflicted lung injury. And a very high effort during non-invasive ventilation is associated with adverse outcome, at least with worsening in oxygenation. So I really think, although this concept has to be further evolved, that it is important that patients with hypoxemic failure under non-invasive ventilation require more extensive monitoring of effort. Thank you very much.
Thank you very much, Leo. I think we have a few minutes for discussion. For us, it's hard to see the room if people want to ask questions. Maybe...
It's Professor Gattinoni.
Oh, yeah, there's a question. Sorry. Luciano Gattinoni. Is there a microphone? Or? You may need to go. So, okay. Yeah. While Luciano is coming at the microphone, Leo, my question for you would be yes or no?
No, just one question. Well, I appreciate all this.
You have to think about it, yeah.
Well, just one question about PEEP. If I raise the PEEP to 30, my inspiratory work will be 0, likely.
Definitely, yes.
So I think this connection that increasing PEEP automatically decrease the drive, that means the patient is, because the patient is better, I don't think is the right message, at least it's questionable.
No. So my point is, increasing PEEP does not decrease drive. Increasing PEEP decreases effort. And if I did not clearly explain that, that's the point. Because how can PEEP affect respiratory effort? I think there's two things. With higher PEEP, less consolidation and perhaps less feedback from these irritant receptors to your respiratory centers, my first slide. The second explanation for reduced drive with higher PEEP is, as Professor Gattinoni explained, if the diaphragm flattens, it can generate less pressure. So, and this is uncomfortable for the patient because the patient wants to breathe but is unable because the diaphragm is flat. So then the drive would be very high, but your effort is actually low. So that's an important point to make. Thank you. So I think, yeah, so your question, Laurent, does the self-inflicted lung injury exist in NIV? In my perspective, in my clinic, I would say yes. If I look at the physiological data right now, if you think about the whole concept, in patients on NIV with hypoxemic failure, I really need like an estimate of respiratory effort. And if the patient is not unloaded after 1 or 2 hours of non-invasive support, I think you can say this patient is failing this way. So we have to think about something else. And then I think it's an interesting discussion, and we had it in our mechanical ventilation masterclass yesterday. So if you were not there yesterday, subscribe for next year, I would say. I think, of course, the esophageal balloon is the state-of-the-art way to go. Very important. But a lot of you will not use it, so we have to look for alternatives. And I think there was a very nice study also in the Blue Journal published some time ago that the pressure measured at the nose could provide a good estimate for, sorry, is that your question? For esophageal pressure.
No, sorry, Leo. I think it's fascinating. I think we need more physiology. We need also more time. We don't have that today, so thank you so much.
Thank you so much.
Thank you.